How was everyone's lunch?
Thank
All right. Well, after sitting in until those dietitian and nutritional sessions, I think we made a pretty decent choice.
Yes, salads.
Not the donuts or tacos. Yes, lunch only. Okay, our next talk is Dr. Janet Blodgett. She's going to be talking on the Aging American Diabetes case studies. She's here from the VA. She's one of our very own, so please give her a warm welcome.
Okay, well, I'm going to stand and prop myself up here. Last night was a long night. Okay, so this is very informal. Gosh, I'm short. What is that? I'm really short. I'm on my tiptoes. You know, I'm so short. I was 4'11", now I'm 5'1".
There's a chair you can stand on.
I'm not going to stand up. That's, you know, that's embarrassing. When I go out to eat with my kids, my older son is 6'4", my younger one is 6 foot. I don't know where they came from, but when I go to eat with them, I feel like I need a booster seat. So anyway. All right, so this is kind of an informal chit-chat on some interesting cases, some of which I've taken care of in years past, but had really interesting teaching points. And so with no further ado, let's get started. So obviously the focus today is on the aging population, and an older individual with diabetes, be it type 1 or type 2, really poses some unique problems. And I think the take-home message that we hear over and over with this population is that treatment needs to be individualized. And part of that is that this is such a diverse population. If you look simply at the way they live, it's very diverse. I have some 80-plus-year-old patients that are living independently in their homes still, mowing their yard, cleaning the house. And then I have some 54-year-old guys who are in scooters and basically very sedentary. So you really have to assess their living situation, not just their housing, but who's in the household. We're seeing a transition in our society where there's an increase in multi-generational homes, and I have a lot of older patients who are living with their sons or daughters who have young kids in the home. So you really need to assess all of those issues because they impact how the patient can be treated, and their eating practices certainly. The other issue is if they're out of the home in some type of a facility, what is that facility? Is it an assisted living facility, or is it a nursing home? And I learned with one of my patients who recently passed away, who died at 92 after having type 1 diabetes for more than 60 years. He was very, very independent, never would go in a nursing home, always lived in an assisted living facility. He had very low vision, so he couldn't take care of himself much. And Medicare really limited what we could do for him in an assisted living facility. They would only give him 2 insulin injections a day, whereas if Sam had been in a nursing home, we could have given him round-the-clock care. So all those things have to be assessed. And the other issue is their functional capacity. Is this a patient, you know, who is wheelchair-bound? Is this an individual who is ambulatory? Sam walked with a rollator walker until his last breath. He never would go in a mobility device. So all of those things are really, really important to define before you assess a patient. So the first case study is a patient that we see a lot of in this setting. We have a lot of very old type 1s that have lived many, many years with their disease and are still functioning. So this gentleman's 72, has had type 1 for 42 years, and reports very labile or widely varying blood glucose readings with hypoglycemic events. He has hypoglycemic unawareness, so he doesn't perceive that he's low until his sugar is in the 40s or 50s. His wife has had to contact EMS a number of times to get their help in treating him. So he presents on referral for treatment using a continuous glucose sensor, and that's something we mentioned this morning. It's a great tool in the elderly population to get a lot of data. He has a lot of diabetes complications. He has autonomic neuropathies, including gastroparesis, erectile dysfunction, and impaired hypoglycemic awareness. He also has a typical peripheral sensory neuropathy. He's got advanced kidney disease, and he's on a lot of insulin. He's on 40 of Blodgett, which is a lot for an elderly type 1. That's always a red flag to me. And then kind of a reasonable or typical dose of Novolog prior to meals. So the issue with hypoglycemia in the elderly is a big one because it's very, very problematic, and they oftentimes don't perceive that they're low until they're quite low. So many older individuals that have hypoglycemic events have lost the initial warning symptoms that we call the adrenergic symptoms, the shakiness, the sweating, partially because they're older, and it's an age-related loss in neurologic function, but also because of long-standing diabetes. It is a form of neuropathy. And so by the time they realize they're low, they're in trouble. And so when you suspect frequent hypoglycemia or profound hypoglycemia, especially if it's overnight, that's an indication for sending a patient to our sensor clinic. And how do you do that here? You go in the diabetes services menu under the consult menu and choose the second option. You choose the outpatient option and then the second one. The first one listed is going to be diabetes education. The second one is continuous glucose sensor. And then you send that consult and we'll address it and get the patient in to place the sensor. So, and again, the issue with the elderly is that their symptoms may be atypical. They oftentimes will present when their sugar is very low. The consequences of hypoglycemia in this population are much greater, and they're much more prone to the serious consequences of profound hypoglycemia. In addition, if you have an individual with some adrenergic dysfunction, which is erectile dysfunction or impaired hypoglycemic awareness, they oftentimes have silent coronary ischemia. And I've always told our trainees that if a patient has a bad insulin reaction, a bad hypoglycemic event, it's like putting them on a treadmill and running them hard, and it can precipitate a coronary ischemic event. So you really want, that's another reason to be really careful about hypoglycemia in the elderly. So we want to be careful about selecting the agents that we choose to treat their blood sugar levels. The goal is not just to get the A1C down with whatever dose of insulin or oral therapies it takes, but we want to do it in a cautious way in this population. So we really recommend, I strongly recommend that you avoid insulin secretagogues, the sulfonylureas and the meglitinides, as well as really being careful with doses of insulin. As I've already pointed out in this case, the patient was on a fairly hefty dose for type 1 of basal or Lantus insulin. Okay, so this is a pretty slide, so I had to throw it in. So you really want to watch using any drug that's going to augment insulin secretion. And in my opinion, the sulfonylurea class at this stage in the game is obsolete. There's really, and unfortunately, for economic reasons in this system, we are forced to use glipizide quite a lot. But a preferred agent in this population are the meglitinides, which are on-demand insulin secretagogues. So if the patient's blood sugar level isn't high, it's not going to stimulate insulin secretion. So if you have an older type 2 who's has a significant life expectancy, a really good treatment is a low dose of a meglitinide, such as Prandin or Starlex and metiglinide in this population. And it does the trick for them. It gets their postprandial glucoses down without the hypoglycemic risk that we see with the older class of the sulfonylureas. Okay, so the ADAAA and the Endocrine Society published some kind of joint recommendations on minimizing the risk of hypoglycemia in the elderly. And a lot of this is common sense, careful education on the symptoms. Lots of times the spouse is aware the patient's low before the patient is. So that individual needs to be instructed on how to treat it. Assess the functional status. We've already mentioned the importance of that. Avoid using short-acting insulin sliding scales, Novolog, Humalog, sliding scales, and discontinue the use of glyburide. We actually made a move to do that in this system about 5 years ago now, and glyburide is a non-preferred secretagogue or sulfonylurea in this system. And the reason is that it has a much higher incidence of hypoglycemia than glipizide does. Glipizide is much shorter acting. So if you have to use a secretagogue, use glipizide or Starlex or metiglinide. And these are the ADAAA 2014 guidelines on kind of individualizing therapy. And again, the important ones are age and life expectancy. And age is very relative these days. And like I've mentioned, we have a lot of highly functioning individuals that are in their mid to late 80s and still living independently. So individualizing treatment. And then also, it's important to do a careful history and also review the medications that they're on to make sure that they're not on something that may complicate their awareness of hypoglycemia. And a big class in this population with a lot of coronary artery issues are the beta-adrenergic blockers, but also our patients with glaucoma are commonly on timolol, which has a very similar effect in diminishing hypoglycemic awareness in patients whose glaucoma is being treated with that agent. Okay, so the CGS, or continuous glucose monitoring, is a great tool, and we have plenty of availability to see patients that may be appropriate for that. And what it does, it's an FDA-approved device that measures the blood glucose level round the clock. So it's really useful in those patients who bring in a glucose monitoring log where they're checking their sugars before meals and at bedtime, but their A1C is high and it doesn't fit. If they don't have blood on the logbook, the glucose values are probably erroneously entered. But, then the cause for all the nurse educators are laughing. We learned that trick a long time ago. If they're sticking their finger, they're going to get blood on the book. Also, if it's written in the same pencil or pen, you know that it's not truthful. So what this does is give you some insight into the postprandial excursions, which is important, and also what's going on overnight, which is really, really important. There are a number of approved devices. Medtronic has the iPro. We are using the iPro 2 now. Dexcom has a device which the patient is alerted to. So without wearing a pump, they can wear the Dexcom glucose sensor and be alerted with trends in their glucose lows. So that's kind of a neat tool that doesn't require the use of a pump. And then there's the Navigator, which is an old device. I have used it on a couple of our patients here that is readable by the patient. So how does this work? So these transmitters have a tiny little sensor, and that's inserted under the skin in the interstitial fluid between the muscle and the skin layer. So the blood glucose readings are being obtained from the interstitial fluid. So there is a disparity between what the sensor is going to read and what a simultaneous finger stick is going to read. But they're fairly accurate, and they're getting more and more accurate all the time. And they're also useful for addressing trends in the blood sugar level. And then we can actually download the data and and I'll show you an example of the glucose patterns we see. So what are indications for the continuous glucose sensor? Number one is hypoglycemic unawareness. Number two, when you suspect nighttime hypoglycemia, that's really a dangerous time because people are asleep. They can sleep through a profound event and get into really serious trouble. And also, as I've mentioned, patients who bring in a glucose record book that looks super good with pre-meal checks, but their A1C is still high. So you know the problem is postprandial or overnight. Okay, so it does require, I just got a consult this morning, an 87-year-old to put a continuous glucose sensor on. So I'm going to call him and make sure, Roxanne's laughing, you're going to be calling him too, make sure that he can do the things that we need him to do to get the data. So it requires some work on the patient's part. They have to do a minimum of 4 finger sticks a day. They have to keep a good record, and this may be tough for this 87-year-old, on the meals that they've eaten, what they've eaten, the timing of their meals, the physical activity they may be doing that day, and the timing and the dosage of their oral meds, diabetes meds, or their insulin. So they have to keep pretty good records, or it's a useless effort. And then it's useful for them to report if they feel that they're low, so that we can see if there's correlation. Yes?
What span of time do they do this?
They do it for a 3-day period. So again, with this 87-year-old that we got consulted on today, we need to make sure that he's willing to do this because it's not a very useful effort if they don't. And here's some examples of the transmitters. This is the iPro 2 now, and then the Dexcom. So they're pretty similar in size, and the technology behind them is very comparable, but the data we get from them is quite different. I think the Medtronic data is a lot more sophisticated than the Dexcom. So here's what we see, and this is a kind of a classic example. So the little red dots are the 4 finger sticks that the patient has faithfully done over the course of a day. But look what he or she is missing. A nighttime hypoglycemic event, a big spike after breakfast. Breakfast is typically a very high carbohydrate meal. And then a drop after lunch, another high after dinner. So although the 4 finger sticks, which is pretty intensive self-blood glucose monitoring, look pretty good, we missed a lot of the excursions that the patient is having every day. So it doesn't tell nearly all of the story. So that was number 1. So case story number 2, alcohol and diabetes. So I looked on the internet and I actually got this picture of this t-shirt, and it'll mean more to you in just a moment. But Vera, it's not just for breakfast anymore. So this patient is 66-year-old, also with type 1. Was diagnosed as 73, and he came to us on an insulin pump that was started by a practitioner in the community. And he has a lot of microvascular complications. He's got retinopathy, peripheral sensory neuropathy, impaired hypoglycemic awareness, erectile dysfunction, and he recently had a pacemaker placed for cardiac autonomic dysfunction. He had a profound resting bradycardia. So I interviewed this gentleman. I did his initial intake, and I think I sat there in front of him with my mouth hanging open when I asked about the alcohol use history, because he loves to drink, and he drinks all day long, from sunup to sundown. He was very, very honest. He said, I like alcohol, and admits to drinking throughout the day. And he's like a connoisseur of all alcoholic beverages. German beer with lunch, gin and tonic at 3 to 4, 3 gin and tonic at 4 in the afternoon, several glasses of wine with dinner, followed by shots of scotch. Whoa. So he's on a pump, and he was wearing the t-shirt, beer is not just for breakfast anymore. This man, who's very charming and very, very pleasant, doesn't come to clinic without some alcohol-related t-shirt on. It's always something. So his initial evaluation was fairly unremarkable. His highest pulse rate was the one we got on his intake, and then he started sliding into the 40s, and we were smart enough to send him to cardiology, and they said he needed a pacemaker. And he feels much, much better afterwards. And then his foot exam was a typical sensory peripheral neuropathy. His A1C was pretty good, but much like the sensor patient we just saw, it didn't tell the whole story. So you can't see the data on this sheet. This is one of the download sheets from his pump. Basically, the gold boxes are high readings and the red are low. So what's your impression? Way too many reds. So he was on a fairly typical regimen. His total daily dose was about 43 units a day. But a majority of that was being delivered as a bolus. He was bolusing with meal or with alcohol. So a majority of his insulin was being delivered as a bolus to cover for his caloric intake. And then he had frequent hypoglycemic events, and some of them were pretty low and pretty scary, 47. And again, you can see on this page all the red numbers, and it's multiple times per day. So he was a good pump patient and sensor patient, first of all, because his alcohol intake was causing him a lot of trouble. And one of the benefits, he's still using the old pump, but one of the benefits of the pump is it will show the patient's trends in their blood sugar levels, so that they can be alerted your blood sugar level is either rising quickly or it's dropping quickly. And this is an example, kind of a cartoon example of what they get alerted to. Again, these are the finger sticks, but with the pump, they're alerted your blood glucose level is changing quickly, so it gives the patient plenty of time to make react to it and make the appropriate decisions so that they can keep their sugars from having as many excursions. Okay, so what's the deal with alcohol and hypoglycemia? You heard a few comments on that this morning, and it can be a big issue, and in this population, it's a big issue. And when in pump clinic, when we see a patient with occasional, very severe hypoglycemic readings in the morning, we always go back and ask the question again about alcohol consumption, because oftentimes that's the issue. So if the patient drinks and they're fasting, they can put themselves at risk for profound hypoglycemia. And if they're a really heavy alcohol consumer who may be getting a majority of their calories in the form of alcohol and not eating, they also put themselves at serious risk for hypoglycemia because they will deplete their glycogen stores or their route to recovery. So how does it work? It shuts down gluconeogenesis. So it blocks the ability of the patient to mobilize glucose stores from the liver, basically. And in addition, patients can have some diminished cognitive function when they're intoxicated, and also be less aware of a drop in their blood sugar level. And I encourage all of you to go on the YouTube. This is a really famous YouTube video that's gone viral recently. Go on YouTube and check out Taser Diabetic. And you'll see a number of YouTube videos, and there's one that happened very recently where the patient was really brutally injured by the police pulling him out of his car. They thought he was belligerent and they thought he was intoxicated, and he was profoundly hypoglycemic, and that happens over and over and over again. So hypoglycemia can cause, alcohol can cause hypoglycemia that can be very sustained. It can last for as much as 24 hours. So when we have a patient on a pump who chooses to drink, oftentimes we'll tell them, reduce your basal rate by 15-20% for about 5 hours after you're drinking. And there are a number of ways to handle that. So the ADAAA, American Diabetes Association, also came up with some tips to sip by. It's a pretty snazzy title. And one of the most important ones is don't drink on an empty stomach. So the other thing we tell our patients is make sure you're eating while you're drinking alcohol. So drink with food. And also sip on a zero-calorie beverage, like a glass of water. So sip on that to maintain your hydration status. And if you're having a mixed drink, choose a caloric-free drink mixer, such as diet sodas, club sodas, diet tonic water, or just straight water. So some pretty handy tips. But the big one is don't drink on an empty stomach.
Excuse me,
Yes?
do you think they remember that?
I'm sorry?
I said, do you think they remember that? Because most of them would probably have some type of Korsakoff dementia going on anyway, and unless they've got a good caregiver, they're probably not going to be very compliant, I wouldn't think.
Well, after a couple bad events, they're pretty compliant. And most of our patients aren't that bad off that they have the Korsakoff dementia. That's a big part of our education at the get-go when we do pump initiation, is we make sure we get a good alcohol consumption history and make sure they know these tips. So, and most of them do comply. All right, so what are the American Diabetes Association recommendations? And this is a repeat from earlier, but it doesn't hurt to reinforce them. So women, 1 drink or fewer alcoholic beverages per day, and I'll define a drink in a moment. For men, 2 or fewer per day, and it's recommended that you check your blood glucose prior to drinking and at bedtime. And again, since most of us, unlike the gentleman I showed you who drinks throughout the day, most of us will have an alcoholic beverage in the evening. So it is recommended that you check your sugar prior to bedtime, and do not exercise after drinking alcohol. And actually, one of the pump trainers that we work with created a perfect storm for herself. She went out to dinner, had a glass of wine in the evening, and then decided to walked her dog after having a glass of wine, and then went to bed. And we downloaded her pump, and she had about 8 hours where the alarm was going off on her pump, and her sugar was around 40 for a very sustained period of time. So we went back and analyzed what she had done, and it was a combination of alcohol and exercise that got her in trouble, and she didn't back down on her basal rate with those activities. So eat food, stay hydrated, limit your total intake, and don't exercise. And this is the definition, and again, Christina mentioned this morning, as a single drink is a 5-ounce glass of wine, 12 ounces of beer, or 1.5 ounces of hard liquor. Okay, and another important tip, and I thought this was really a neat little handout, is that glucagon will not reverse a alcohol-induced hypoglycemic event. If you think about it, it makes sense. Glucagon is a counter-regulation hormone. It works by causing gluconeogenesis or glycogenolysis, and that's blocked by alcohol. So you have to give the patients glucose to reverse it. Okay, dizziness, nausea, and vomiting, case study number 3. This is a gentleman I took care of a long, long time. He had type 1 diagnosed in '88, and he had lots of complications. He had nephropathy and had a renal transplant in 2006. We actually tried to get a combined renal pancreas transplant for him, but they declined. He had severe peripheral neuropathy, recurrent foot ulcers, no amputations. He had proliferative retinopathy with multiple laser treatments, terrible gastroparesis, horrible postural hypotension. At the end, he was not able to stand upright. He was confined to a wheelchair and erectile dysfunction. So he started rejecting his transplanted kidney, and that progressed very quickly. He also had hepatitis C cirrhosis. He had a mischievous period of 11 years where he was doing IV drug use, chronic pancreatitis, and I diagnosed a melanoma on the instep of his foot, the strangest melanoma I've ever seen. It was right on the instep of his right foot. It was an early, thankfully. So the last year or so of his life, he had recurrent presentations to the emergency room with intractable nausea, vomiting, and hypotension to the point, like I said, where he was no longer able to stand upright. He would be treated in the ER with IV fluids, and he did have a gastric emptying study which showed very significant delay in gastric emptying, 79 minutes, and normal should be 37 minutes. So we tried a scenario of different drugs, Reglan, metoclopramide, and erythromycin. Erythromycin, the antibiotic, 250 milligrams taken about 30 minutes before a meal, works to enhance motility in the stomach. And it's actually very effective. It doesn't have the side effect profile that Reglan does with long-term use. And he got to the point where he couldn't eat anymore orally, and he, for the last year or two of his life, his diet consisted of 4 cans of Mepro a day, about 2,000 calories. So gastroparesis is, I think, a grossly underdiagnosed complication of diabetes. It's actually pretty prevalent, and the symptoms are very, very, very subtle. And what happens is you get a neuropathy of your stomach and the rest of your gut, so that patients, when they eat, especially if it's a high-fat meal, it just sits in the stomach and they can actually get a functional gastric outlet obstruction and start vomiting. And again, if they have dysmotility in the stomach, it usually affects the esophagus and all the way to the rectum. So commonly, these people may not have many symptoms relating to the stomach function itself, but instead may have constipation and or diarrhea, and that's actually the more common scenario. So about 40% of type 1s and 30% of type 2s have this, and we're not diagnosing it in that number of patients. We're not identifying it. So again, the symptoms can be very subtle. I think one of the worst cases I ever saw was a young girl with type 1, and I did a gastric emptying study because I couldn't control her diabetes. Her glucoses were just really, really chaotic, and she was very compliant. So we did a gastric emptying study, and they actually called me on it because she had a functional gastric outlet obstruction. She wasn't emptying her stomach at all, and it was really, really distended. She was unaware of it, and they actually ended up having to decompress her. More commonly, they'll have subtle symptoms, post-meal bloating and early satiety, where when they eat part of a meal, they're full, so they'll start nibbling. They'll eat a meal over a lengthy period of time instead of sitting down and finishing a meal in 20 or 30 minutes. They can actually have a distended abdomen, like this young girl did, and some epigastric discomfort. And then they can have vomiting after eating, and commonly they'll describe vomiting in the middle of the night, and what they vomit is undigested food and or medication. It's a very miserable condition for patients. And there's a number of conditions that can cause gastroparesis, but diabetes is number 1. And basically, you just have impaired relaxation of the entire stomach, so it becomes, as I mentioned with the young girl, that I think she was 24, the stomach becomes very distended. and very uncomfortable. So how do you diagnose it and treat it? Now, the first step is to do the 4-hour gastric emptying study. And again, I think we need to be doing a whole lot more of these than we are, because especially insulin treated, as you'll see in a moment, clearly this makes a big difference. So you want to exclude iatrogenic disease. You want them on a diet that's low in fat and low in fiber. Fat will delay gastric emptying. And as with any neurologic complication of diabetes, improving their blood sugar control will improve the gastric motility. And then there's drug therapy. There's metoclopramide or Reglan, erythromycin, and domperidone. Domperidone is not available in this country. It's available in Canada and on a compassionate use basis in this country. We had a drug here called cisapride that was really effective. It was a great drug. It really worked well, but there were several case studies of a lethal cardiac arrhythmia with it, a Torsades, so it was pulled off the market. But is also available on an individualized appeal to the Food and Drug Administration. And then antiemetics, because the nausea is a big part of the symptom syndrome. And then nutritional support. You know, this is a big problem with these people. They get to the point where eating is so uncomfortable they stop eating. So you really have to partner their care with a dietitian. And then there's some new treatments that are really pretty promising. One that's being pretty widely done is injecting the pylorus with Botox to relax the sphincters so that at least the stomach empties. And then putting a G-tube in to kind of decompress them, which we had to do emergently in this young girl. If they get to the point where they cannot eat by mouth, you have to place a feeding tube. And the feeding tube is placed in the small bowel because the stomach doesn't contract, so you can't put a G-tube in. You put the feeding tube in the jejunum. And then they may have to go on TPN. And there's another new treatment, a gastric stimulator, which actually is like a gastric pacemaker. It sends an electrical stimulation to the stomach to improve motility in the stomach. And there's 2 companies that make these. Medtronic is one, and it's a surgical procedure to place it. And the gentleman we've mentioned, I did make an appeal to have a pacemaker put in him, but he was not eligible. And then if it gets really extreme, they can actually do a partial gastrectomy on the patients. And usually that happens when the patient is no longer able to be adequately nourished. Okay, so in a patient on insulin, like the type 1 young lady that I mentioned, or my patient that I mentioned more recently, if they're on insulin, it's very tough to regulate their diabetes if they have bad gastroparesis. Because if they take a dose of rapid-acting insulin before they eat before their meal, like they're instructed routinely to do, that insulin's going to peak long before the food is being absorbed and before the glucose level starts to rise. And that's what happened with this young girl, is that her sugars would go way up and then they'd crash because of the mismatch between the insulin effect peaking and the carbohydrate absorption. So this is one indication, in my opinion, for use of regular insulin, which has a much less sharp peak and a longer duration of effect. So patients with gastroparesis tend to do much better with regular than with Novolog insulin. Okay, case report number 4. How much insulin is too much? This is an interesting guy, 68-year-old gentleman with type 2 diabetes, diagnosed in 2001, although in reviewing his lab data, he reported high sugars that he was told dated as far back as 1982. Really strong family history of type 2 on his mother's side of the family, and was on a ton of insulin. He was on 100 of Blodgett twice a day and 50 to 60 of Novolog before meals. There's no point in doing this. So the first thing we get one of the indications for sending a patient to us is insulin resistance, where you're just cranking the dose of insulin up and you aren't getting anywhere. The first thing is to assess the patient's compliance. Ask him how often. I usually ask how often in a typical week are you missing these injections. The second thing is to very simply have them pull their shirt up and show you where they inject. And this guy was injecting primarily in his legs, which is okay for the glargine, but not for the Novolog. And then making sure that they use separate syringes. Glargine is very, very acidic, and if they use a syringe for Novolog or glargine and then use it for Novolog, it's going to diminish the effectiveness of the Novolog. So you really want to make sure they're using a separate syringe for each injection. And actually, finally, we're able to use insulin pens here much more than we have in the past. So that becomes a non-issue with those individuals. And he wasn't able to take an insulin sensitizing drug. He initially was GI intolerant to metformin, but he wasn't treated properly. He wasn't on a calculated dose, and then had very significant edema on pioglitazone. Despite having diabetes a really long time, he had really an unremarkable retinal exam, and he did have significant proteinuria, and he had painful peripheral neuropathy and was on pregabalin or Lyrica at that time. His complicated medical history, a lot of problems. Pancreatitis with pseudocyst, GERD, who's an obese gentleman, had GERD, and COPD, former heavy smoker. He had a CVA in 1988, severe sleep apnea, coronary artery disease, hypertension, and some mental health diagnoses. So this 24-hour dietary recall, I think the best investment for a patient, we tell our weight management patients here, is a measuring cup. You know, they always say, I just have a bowl of cereal. Well, the bowls can be like this, or they can be like this. So, and he was having a big bowl, probably 3 to 4 cups of Cheerios, plus a banana in the morning, skips breakfast, and then would dine on a 12-inch Subway tuna, which is the second highest calorie Subway. And that alone was 92 grams of carbs with chips and water to drink. And then his snacking was really out of control, and he wanted to be well nourished, so he drank 2 cans of chocolate Ensure. So chocolate Ensure has 40 grams of carbs in it. He was having 2 of those in the evening just to stay well nourished, and he was a big man. So his physical exam was stunning. When I went back and looked at his record, he had gained 77 pounds over a period of about 4 or 5 years, since April of 2012. I guess it was 6 years. He gained 77 pounds. And that was a period during which he was going in and the providers were just cranking his insulin up and up and up. Your A1C is not good, let's go up and up. Not bothering to take a dietary history or educate the guy on limiting carbohydrates. And despite being on that massive dose of insulin, his A1C was terrible. His fasting glucose was high. His triglycerides were high. His LDL was great. He was on a big dose of a statin, and his HDL was very low. And he wasn't testing his blood sugar. So he went to diabetes education class and learned what a carbohydrate is, and was advised to restrict his intake to about 45 grams of carbs per meal. And he did it. And then he was also put on a graduating dose of metformin. So oftentimes patients are put on that and they're not, first of all, they're not graduated on the dose and they're not told to take it at the end of the meal. It makes a big difference. His weight came down 18 pounds in 10 weeks. His blood pressure was great. We were able to back off on some of his meds. Still had a peripheral neuropathy, and he had an ulcer on his second toe of the right foot. I like that slide so much it proved in twice, I think, yeah. So this is his Followup Labs, glucose 101, kidney function normal, LFTs normal, triglycerides were better, his A1C was 6.5 from 13, 10.3 after about 8 months. Microalbumin normalized, and we titrated his levothyroxine. So there's several points with this case, and one is that carbohydrates patients need to be educated on carbohydrates. And there's a lot of controversy, in my opinion, on how many carbohydrates patients should have. And I've actually looked at this in the literature a lot of different times, and the consensus seems to be from the National Academy of Sciences recommends no less than 120 grams of carbs per day. But the science behind that is really quite mysterious. The recommended daily allowance for a person on a 2,000 calorie per day diet is about 300 grams of carbs, which obviously for a diabetic patient is a lot. Atkins is on the extreme end of the spectrum, recommends 20 grams of carbs per day. I think no one would argue that that's too restrictive. The Zone diet recommends that about 40% of the total daily caloric intake be in the form of carbs. So there's really a lot of different opinions on carbohydrate recommended amounts of carbs. However, dating back to the days prior to insulin in 1922, it was realized that by restricting carbs, blood sugar levels came down. And before insulin was available, that's how diabetic patients were treated, is they were put on a very low or no carb diet. And then in the early 1970s, lower carb, higher fat diets became popular. And we didn't get fat at that time, which is very interesting to me. It wasn't until we started carbohydrate restricting in the 1980s and 90s that Americans got fat. The issue with obesity is really has been a rapid increase in our average weight over the last 2 decades. Okay, so there's no question, as I've mentioned, that restricting carbohydrates will help blood sugar levels. And I always tell patients, there's 2 ways to lower your sugar. I can let you continue eating like you are and give you whatever dose of insulin, like they did in this gentleman, 40 to 50 units of Novolog before a meal, or you can decrease the amount of carbs you're eating. And unfortunately, he chose the second. And it is true that in patients whose carb intake is quite low, that their blood glucose level to meet requirements in the central nervous system can be met through alternative pathways like gluconeogenesis. How long that can occur is not really known. So I like this cartoon. You went on an Atkins diet and lost 90 pounds, lowered your cholesterol, cured your blood pressure, and now you're walking 5 miles a day. But I'm warning you, a low-carb diet is bad for your health. So I think that kind of humorously points out the fact that certainly carb restriction is very important. And then this is a slide from a study published in the New England Journal of Medicine about 9 years ago now, showing the difference between, and it was a fairly sizable study, a low-fat versus a low-carbohydrate diet and weight loss, and the low-carb was more successful. Okay, I'd be happy to answer any questions. I was on a low-carb diet for a week and lost 3 inches off my smile. Any questions? You guys look sleepy. Starbucks kiosk is about to be flooded.